Welcome back. So this is a continuation of the lecture series on congenital anomalies of the kidney and the urinary tract. So far we have discussed about the cystic diseases of the kidney, and we discussed about multicystic kidney, dysplastic kidney, cystic renal dysplasia, medullary sponge kidney, autosomal recessive and autosomal dominant polycystic kidney diseases. And then just miscellaneous, we mentioned about the one which is associated with the maturity onset diabetes mellitus, the one which is seen in tuberous sclerosis, and then the last one which was we just briefly mentioned the name about is the nephronophthisis. Now let's move on to the next anomalies, which includes the anomalies of the structure. Here we begin with anomalies of duplication. So when the ureteric bud is arising from the mesonephric duct, instead of one there could be two ureteric buds that arise, and hence that can give rise to two different draining systems, or one ureteric bud divides into two before invading into the metanephric mesenchyme. They could be complete or incomplete, and there will be an upper pole and a lower pole mighty, and upper pole ureter usually ends up having a ureterocele. We should remember this. So here is an example of the duplication anomalies. As you see, this kidney has an extra ureter. There is one renal parenchyma appearing, which is same as on the other side, but there are two ureters which are draining into the bladder, and the ureter which is draining from the upper pole has a ureterocele. And this is the intravenous pyelogram, which is demonstrating the same picture with a ureterocele here. There is a law that you should remember called as Wiegert-Meyer law, which says that upper pole obstructs and the lower pole refluxes, meaning the upper pole ureter is inserted ectopically inferomedially and is associated with ureterocele, whereas the lower pole inserts orthotopically, that is the normal insertion of the ureter when it's one, and then it is into the trigon of the bladder, and the upper pole will be obstructive in nature because of the ureterocele, and the lower pole will have reflux in it, and this is known as Wiegert-Meyer law. And this is the demonstration of the same thing. As I said, the upper pole is obstructed, having hydronephrosis, and this is the lower pole. What are the anomalies of the migration? There could be horseshoe shaped kidney with this fusion of the lower ends of the kidneys. There could be crossed fusion ectopia. I will come to some cartoon pictures and you will understand better. A pelvic kidney where the kidney is located in the pelvis. This is important because when kids undergo a renal ultrasound and they are looking for in the retroperitoneal space, they find only one kidney. So they have to make sure that there is no other kidney which is located in the pelvis that they are missing. So they try to do an ultrasound of the entire abdomen to look for it. And there is something called as pancake kidney, and I recently saw a case of pancake kidney, and you will see that the both kidneys are just fused completely so that it looks like a pancake. And here is an example of the horseshoe kidney where the lower inferior poles are fused and they get obstructed when they are migrating, and this is the radiological image of the same. Here is the crossed fusion ectopia, meaning the kidney has crossed and then fused. So it's a crossed fusion ectopia, and this can be demonstrated using urography. Different types of fused, non-fused ectopias include, this is the crossed fused ectopia. So this is the normal kidney with the ureter in the normal position. This is the kidney from the opposite side which has come here and fused. Here there is crossing of the kidney but it has not fused, so this is crossed non-fused ectopia. And here this kidney has gone to here and this kidney is supposed to be here, so this is bilateral crossed ectopia without any fusion. Pelvic kidney is possible, and kidney is lying in the pelvis, and when you do a renal ultrasound you will just see one kidney. When you are suspicious for this and you're not able to make it on the ultrasound, because ultrasound is all technical, with a good technician able to find it and a rookie technician will not, you do a MAC3 scan, which is a functional scan, and it will light up wherever the kidney is and you will know if there is a second kidney or not. Coming to hydronephrosis and obstructive uropathies, UPJ obstruction, seen in 1 per 1500 live births, more common in males, can be unilateral or bilateral, but more common unilateral and more on left side. MAC3 scan, as I said, has two parts. One is it can tell you the functionality of the kidney, and the second thing, it can tell you whether the obstruction is, whether the hydronephrosis is obstructive or non-obstructive in nature. Because hydronephrosis just means dilatation of the ureter. Some people can have just a dilatation of the ureter as a normal variant without any obstruction. Hence, MAC3s can help in those cases to differentiate. And when you have this, you do the pyeloplasty, which is relief of the obstruction, to relieve the obstruction. They can go into clinically presenting as a Dietl's crisis, which means when they have a binge drink, they will develop acute flank pain because there is a lot of urine that is made from the binge drinking, and just leads to obstruction of the urine flow with sudden stretching of the renal pelvis and the making pain. So this is a bold point. And this is the UPJ obstruction on the MAC scan, and this is how you can demonstrate it is dilatation of the renal pelvis with an obstruction right here. Posterior urethral valves, commonly seen in males, again 1 in 500 male births. There is a keyhole appearance of urethra on the ultrasound, and I will show you what exactly that looks like. It's a wide spectrum of disease presentations can be there. It acts like a pop-off valve mechanism, meaning it won't let any urine flow out from the bladder. What's the goal is to relieve the obstruction. How can you do that? Either you can do the ablation, or you can do vesicostomy, which is putting in a hole in the bladder, and the kid will be peeing through the intra-abdominal valve through that hole in the bladder. And it's important to treat it because it's one of the causes for reflux in males. And this is how it appears on ultrasound, and you can see this is what I was talking about, the keyhole appearance, the posterior urethral valve, and this is the VCUG with the contrast agent, and you could see the obstruction. So sometimes you can pick it up by VCG as well. A little bit of ACE fetopathy, because ACE inhibitors are contraindicated in pregnancy, so you should know what happens exactly there, why they are contraindicated. So they can cross the placenta, and exposure during the second and third trimester causes oligohydramnias with intrauterine growth retardation, because they lead to renal dysgenesis. And when you do a biopsy in these kids, you will see that there is tubular dysplasias. They interfere with the normal fetal development as well. There have been no teratogenic effects seen with periconceptional use or cessation of use during the first trimester. The newborn infant presents with renal failure, and when you do a kidney ultrasound, you will see there is increased echogenicity and there is a loss of corticomedullary differentiation. And this is an important finding on the renal ultrasound for most of the kidney disease in the kids. There is increase in the echogenicity, one part, and second thing is the corticomedullary differentiation is lost. And the third thing is you look for the cysts, like in other diseases. Those are the three important things that you can come across in renal ultrasound. And this is how the renal ultrasound looks like: a normal kidney in a 2-week-old girl, and here's the ACE nephropathy in a 30-week gestational age. Something about renal hypoplasia, and I think you should know about this because, as I said, this is one of the risk factors for development of CKD in adults who do not have the classic risk factors like diabetes and hypertension. Diabetes is the most common cause for CKD in adults, followed by hypertension, and which constitutes to roughly around 80 to 90%. The remaining 10% is from GM. So renal hypoplasia, inadequate branching of the ureteric bud. If you remember from my embryology talk, I said that it depends on the ureteric bud, which undergoes branching, and that branching determines the number of nephron formation. So if there is inadequate branching of the ureteric bud, then you will have less nephrons smaller sized kidneys. When you have smaller sized kidneys, it is you are exposing the small kidneys with a bigger body surface area, because as the kid grows, becomes an adult, so there is more blood to clean up, and there are small kidneys, so they undergo initially hypertrophy, and then followed by, due to increased pressure, they undergo development of what is called as FSGS, and that is a tip variant. Pathologically, the lesions of the glomerular sclerosis is seen in the tip. That's why it's called as a tip variant, and that is associated with hypertension and proteinuria. And sometimes you can think of, like, if it's just segmental, you just try to get rid of it in order to treat hypertension. Very rarely you do that, and that is what I was just talking about, which is the oligonephropathy of prematurity, in the sense that if this branching starts from around 8th or 7th week of gestation, goes till 33 to 34 weeks of gestation. So you can imagine, if there is a premature birth, then you are essentially preventing the morphogenesis that is supposed to happen in the later part of the third trimester. Hence they will be born with less nephrons. Again, less nephrons, hyperfiltration, leading to the same phenomena of, like, FSGS, then followed by hypertension and proteinuria. And this is what it has been demonstrated in one of the fluorescent tomographic imaging of a developing murine kidney, to show that morphogenesis goes on throughout the pregnancy. Hence, a full-term baby will not have this issue, whereas a premature babies will have this issue. That's why it is important, when you are taking a history for a CKD patient who does not have hypertension and diabetes, to ask the birth history to see if they were born prematurely, to suggest the less number of nephrons, because there is no test available really to determine the less number of nephrons or oligonephropathy of prematurity. With this, we complete the discussion of congenital anomalies of the kidney and the urinary tract. Thank you for watching the videos. Stay tuned then for new lecture series which will be coming soon.